Assalamualaikum warahmatullahi wabarakatuh, and a very good day to my beloved lecturer and member of the floor, ladies and gentlemen. My name is Amiruddin bin Junli. I am a student of Bachelor and Medical Health Science, Open University Malaysia, Petaling Jaya Learning Center. And today I would like to do my case study presentation. It's all about the management and care of the patient with polytrauma. Prior to my clinical placement for the subject NBCP2626 Emergency and Trauma Care, and I've been posted in Hospital Tuanku Jaafar Seremban in Emergency and Trauma Department. Resuscitating and treating patients with polytrauma is not an easy task. Every time when we're attending patients with polytrauma, we need the interdepartmental collaboration. For example, if we're attending patients with a polytrauma and intra-abdominal injury with a femur fracture, we need the interdepartmental collaboration, such as the collaborations with orthopedic department and also surgical department, and sometimes with the anesthesia department, to ensure the delivery of treating patients is holistic and successful. Study from Niki Samudin, Kamarul and Sharifa Mastura in 2015 shows that road traffic accident RTA in Malaysia increased each year from 279,000 in 2002 increased to 449,000 in 2011, with 19 fatalities each day. World Health Organization's WHO ranked Malaysia at 20th place in the world for death due to RTA. They also explain multiple injury may occur due to RTA that may cause death, such as lower limb deformities, traumatic brain injuries, and intra-abdominal injuries. Before we going further, I would like to explain the terminology that we use in this case study. The terminology of polytrauma is derived from Greek words, which is poly means multiple and trauma means wound. Therefore, the words polytrauma indicating the complex injury of different anatomical regions. However, in this modern world, the modern definitions of polytrauma was a syndrome of multiple injuries of defined severity by using injury severity score more than 15 with consecutive systemic reactions which may lead to dysfunctions of remote organs. What is abbreviated injury score AIS and injury severity score ISS? The abbreviated injury score AIS introduced to assess the severity of multiple injury to a given anatomic organ and graded as 1 to 6 in ascending severity and 6 being unsurvivable. This score decided and assigned to an injury by cross-referencing at least 2 or preferentially 3 sources of information, which are radiological data, operative notes, and communication with the operating team with surgeon. There are 5 body regions, and the top 3 scoring injuries are identified. Each of 3 AIS scores are squared, and the sum total constituted as injury severity score ISS. So this is an example of injury scored by abbreviated injury scale. As we can see, each of severity of injury scored as 1 minor, 2 moderate, 3 serious, 4 severe, and 5 critical, and last but not least 6, which is fatal. Assistant Medical Officer AMO needs to be extra careful during assessing and doing any interventions related to polytrauma patient. Each of action done may increase the severity of patient condition, especially towards patients who had severe and unstable injury. For example, patient polytrauma with spinal injury. The AMO needs to extra careful attending them because it may lead to spine damage that may paralyze patient in future. AMO also need to know how to perform assessment process and doing life-threatening interventions In pre-hospital care (PHC) setting and emergency and trauma department (ETD) setting, AMO should be able to perform primary survey, doing interventions such as needle thoracentesis, three-way occlusive dressing, and applying equipment that may help in resuscitating patients such as immobilizations and splinting devices. Knowledge and skills in managing trauma patients is a must. Dealing with multiple injuries patients is another level of care that each AMO needs to do extra care to deliver the best treatment to the patient. So let's proceed to the presentation of the case. My patient was 16 years old male gentleman, came to our red zone on 29 June 2020 and worked as a student. The patient having chief complaint LHMVA motorbike skidded sustained multiple abrasion wound over body today. So the history of present illness. Patient was a motorbike rider, skidded during went to shop, tried to avoid another car from front. Patient not wearing helmet, fall at the left side of the road. The primary survey was performed towards this patient. The general conditions was alert and conscious. The airway assessment, airway pattern, patient able to talk, no vomiting, retrograde amnesia, unable to recall what was happened on that day. On breathing assessment, trachea was central, good chest expansions, good air entry, no paradoxical movement. The circulation, there is deformity of a left distal upper limb and two-third left femur deformity. CRT was less than 2 seconds, warm paraphrase, pulse palpable bilaterally. The disability examination, the GCS was full, 15/15, E4, V5, M6. Patient unable to recall what is happened during accident. Pupil reactive to light, 3 mm bilaterally. The exposure done, there is deformity over distal left wrist, open wound 5 cm times 2 cm, and deformity over two-third left femur region, multiple abrasion wound over face, left hand, bilateral leg, laceration wound over left leg, and active bleeding over left frontal head. The vital sign during arrival was blood pressure was 101/52 mm mercury, the temperature was 36.9, the glucometer was 6.3 millimole, the pulse rate level tachycardia with 113 per minute. Pain score was 9/10. The saturation of oxygen 99% under high flow mask. The respiration rate was 20 per minute. The GCS is full. The ECG that we performed shows that heart rate was 114 per minute. There is no changes. The P wave was normal. The interval was normal. The segment was normal, and it shows the sinus tachycardia. Patients having no medical illness and there is no previous surgical history. The social history from her mother. He was second child of 4 siblings and patient was normal at home. There is no suicide intentions during an accident. The assessment finding after doing the primary survey of this patient shows then the assessment of head and neck. From the inspections, there is a laceration wound over left frontal head with 1 cm times 0.5 cm and actively bleed. Multiple abrasion wound over facial region, no hematoma, no burn scar, no obvious deformity seen, there is no punctured wound. On palpation, tracheal was central, no crepitus, no subcutaneous emphysema. Measurement of GPP is not increased. Sign anterior and posterior. The inspections, upper limb deformity of a distal left wrist with multiple abrasion wound. Lower limb open wound 5 cm times 2 cm and deformity of a two-third femur region with multiple abrasions wound and laceration wound over left leg. On palpation, tender on palpation of a distal left wrist. Otherwise, there is no deformity felt from other parts. Lower limb palpation, tender on palpations over two-third femur region. left femur region. Otherwise, there is no deformity felt from other parts. Chest and lung assessment finding. By using the IPPA, the inspection tracheal was central. There is no chest wall wound, no paradoxical movement, good chest expansion. The palpations done, there is no crepitus, no subcutaneous emphysema, and chest spring was performed and it's negative. The percussion on the patient, patient have no hyperresonant sound and no dullness sound, equal AN3 on auscultation. Cardiovascular system assessment finding. Overall patient pink, good capillary refill time, less than 2 seconds. There is no sign of hypoperfusion. Auscultations done, double rhythm, no murmur, no muffled heart sound, and palpations, pulse palpable on the radial pulse bilaterally with good pulse rate and good pulse volume. Alimentary system, there is no obvious abrasion wound and laceration wound seen over the abdominal parts. Soft, not tender on palpation. The percussion was normal. The auscultation was normal vowel sound and measurements of liver is not enlarged. Ophthalmic inspections, no laceration wound, abrasion wound over bilateral eyes. There's also the same result on nasal and ear inspections, no nasal bleeding or no ear bleeding. There is no deformity seen. There is no laceration wound and abrasion wound seen. Inspections on throat, not injected, and there is no bleeding from the throat side. The central nervous system examination shows that mental status was good according to the GCS 15/15. Coordination and gait test. We are unable to assess gait test due to the patients having deformity of a left femur region. Patient able to mention date, time, and name. However, patient unable to recall what happened during the accident. Inspection on genitalia side, there's no bleeding from the genital. The dermatome test, pinprick test, and light touch test is normal. So this is the figure where is the injury was. There is actively bleeding over the laceration wound over the left frontal 1 cm times 0.5 cm, and there is multiple abrasion wound over facial region. The deformity, they still left hand with abrasion wound and open wound 5 cm times 2 cm and deformity over 2/3 left femur region and added with abrasion wound over bilateral legs. Motor test, power was good, sensation was normal, and reflexes was good over the right side of upper limb and lower limb. However, we are unable to assess the left-sided of upper limb and lower limb due to the deformity seen. However, the sensation was good over the left upper limb and lower limb. So the diagnosis from these patients was LHMVA, motorbike skidded, sustained open left mid-shaft femur fracture, left radius ulnar distal and dislocation, and laceration wound over left frontal head region. So our discussions on medical surgical management of the patient. We were performing the primary survey and followed by secondary survey towards this patient. Assessing airway patency, patient able to talk, hence the airway was patent. Patient was put with a cervical collar, and then assessment of breathing and breathing adequacy and deformity. Patient able to breathing spontaneously and no accessory muscle used during inhaling and exhaling. Performing chest spring and chest palpation to determine any life-threatening injury. Chest spring was negative, no sign of pneumothorax, no sign of open pneumothorax, no sign of cardiac tamponade seen. During assessment of patient perfusion, patient having good capillary refill time, no sign of cyanosis, adequate pulse rate and pulse volume, no sign of shock. Deformity on distal left wrist and open wound 5 cm times 2 cm and deformity over 2/3 left femur region, upper limb and lower limb spleen applied to this patient. Inserting 2 large bore baranula and run 2 pints of 1 raw muscle line in view of tachycardia. Homeostatic suture applied on this patient's left frontal region due to the laceration wound 1 cm times 0.5 cm active bleed. The patient's neurological on assessment is GCS was 15/15, E4, V5, M, Moto 6. Pupil reactive to light, 3 mm bilaterally. The log roll was performed towards this patient to assessing patient's mind and other possibility parts of injury. There is no obvious deformity, contusion, abrasion wound, punctured wound, burn scar, laceration wound, swelling over back of body. Anal tone was intact, and we're taking the history taking and doing top-to-toe examinations. Refer to the case clocking that I provide together with this presentation. And we're doing the fast and e-fast scan. We're doing 3 times of fast scan. There is no free fluid seen. And we're performing blood and radiological investigation. We're taking the blood taking. We take full blood count, actual blood cases, and group and cross match. The results of FBC times 1 was total white count is 23.01, red blood cell count was 5.32, HB was 15.7, hematocrit 45.7, and platelet 34.4. However, due to tachycardia during the observation, after 3 hours in our department, patient shows tachycardia in range of 110 to 150. So 115. So then we're taking another FBC result shows that the total white count increased to 25.39, the RBC decreased 4.32, the HB was decreased to 13.2, the hematocrit decreased to 37.9, and platelet remained the same, 34.8. We ordered the X-ray for this patient, which is a skull X-ray, chest X-ray, cervical X-ray, pelvic X-ray, left wrist, left femur, left tibia fibula X-ray, left knee, left hand X-ray. So the X-ray reviewed, there is no obvious fracture seen except for the left femur. There is mid-shaft femur fracture, and left wrist shows dislocations at radius and ulna. The ECG was performed. There is sinus tachycardia. So we offer this patient with analgesia, IV tramal 50 mg, and added on with IV pentanol 25 microgram stat. So continuous observation on pen score and giving analgesia accordingly. The ATT was given stat, and we serve antibiotic to these patients with IV cefuroxime 1.5 gram stat and IV flagyl 500 mg stat. In view of decrease of HB and also tachycardia, we also serve this patient with tranexamic acid 1 gram and continues with maintenance of tranexamic acid 1 gram over 8 hours. So we're performing the vital sign monitoring. Noted tachycardia ranging from 110 to 115 per minute upon observation. The baseline monitoring, we monitored the HB. So the HB was 15.7 upon arrival and dropped to 13.2 after 3 hours of observation. However, there is no GCS drop upon observation in ETD. So we're giving 2 pint warm normal saline due to the tachycardia and also the HB drop. We perform in the nursing care towards this patient, such as an oxygen therapy. The clothes were changed to the hospital attire, or wound exposed, analyzed, and also dressing by using antiseptic and cloths with gauze and KMG as indicated. Vital sign monitored every 15 minutes. Analgesia served adequately. Patient put on warmer to prevent hypothermia, and last but not least, do any intervention as per medical officer order by time to time. And these patients also referred to prospective primary team, which is orthopedic department, due to the open fracture over the mid-shaft femur, left femur, and dislocations of the left radius ulna. And we also request for group and cross match to the blood bank. And we transfuse 1 pint of Bachelor due to the tachycardia and HB drop. And also we referred this patient to the radiology department for CT brain due to retrograde amnesia. At the end, this patient was admitted to orthopedic ward. So to the nursing diagnosis, we're afraid this patient having risk of fall due to non-assisted movement and weakness. Hence, this patient maintain bed rest or limb rest as indicated, provide support of joints above and below fracture site, especially when moving and turning. This patient also having acute pain due to fracture and effects on unpleasant sensory after trauma event. So we assess and record the patient's level of pain, utilizing pain intensity rating or pain score. Note any relieving and aggravating factors and non-verbal pain cues such as changes in vital signs, emotions, and behavior. So we maintain the immobilizations and support, provide emotion support and encourage the use of stress management technique, and provide therapeutic touch and giving analgesia adequately to this patient. We also afraid about the risk of infections. Therefore, we inspect the skin for pre-existing irritation or breaks in continuity, and we monitor vital signs, not presence of chills, fever, malaise, changes in meditation, and serve antibiotic. We are also afraid these patients will have constipation during the admission, so we assess the patient's usual bowel pattern and habits, and administer stool softener and a muscle laxative as prescribed in what's later. Knowledge deficient regarding condition, prognosis, treatment, self-care, and discharge need. So we discuss this patient, we discuss the case with the patients and family member about the diagnosis, result of any examination done, prognosis, and about things to concern due to the patient's current condition, and support patient to calm and accept his current condition. As a conclusion, as treating and resuscitating patients with the polytrauma is a tricky and challenging, each assistant medical officer needs to updating their knowledge and to be alert all the time. We also need to stress the continuum of treatment towards patients from the emergency and trauma department to the respective wards to better outcomes of patient. Thank you to listening to my presentations and hope to see you again soon. Take care. Assalamualaikum warahmatullahi wabarakatuh and goodbye.